Dr. Vida, I think we can go, Dr. Vida.
Okay, sure. Just 1 second, there's an echo on my side, but okay, got it now. Hi, very good evening to everyone in attendance. Welcome to the second week of the Neurology webinar, and our topic today is seizure or not. So today we're very privileged to have our chairperson, Associate Professor Dr. Koo Ching Sung, and our speaker, Dr. Shirley, with us today. So before we start, let me introduce our chairperson for today. So Associate Professor Koo, he is a consultant neurologist at the Faculty of Medicine, University Kebangsaan, Malaysia. He completed his MD with an honours degree and then obtained his MRCP UK. He then went on to pursue his neurology training at UKM. He also holds a fellowship for the Royal College of Physicians of Edinburgh, Glasgow, and Ireland. He's also one of the selected candidates for the Korean Epilepsy Society Fellowship in 2018. He is currently serving as the Vice President of the Malaysian Society of Neurosciences and the Honorary Treasurer of the Epilepsy Council. He's also the Vice President of the Malaysian Society of Malaysia, which is a patient support group. He leads the conference task force of the Young Epilepsy section of the International League Against Epilepsy, ILAE, and is also a member of the Communication Strategy, Emergency Treatment, Prioritization, ILAE Care Pathways, Acute Symptomatic Seizures, and Update Seizure Classification Task Force of the ILAE. He's also an editor of the BMC Neurology, and his work has been published in multiple journals, including the Neurology, Epilepsy, and Drug Discovery Today, to name a few. So without further ado, I'll pass the floor to Prof. Koo to introduce Dr. Shirley.
Thank you so much, Dr. Vidya and College of Physicians of Malaysia, for inviting me to chair this very meaningful webinar. And it's my privilege and an honor to introduce the speaker of today's webinar, Dr. Shirley Lee, who is my keen friend. Shirley Lee is a neurologist who is currently practicing in Kuala Lumpur General Hospital. She was previously serving at Queen Elizabeth Hospital in Sabah for more than a decade. She has a keen special interest in epilepsy, where she did a year of fellowship in epilepsy with Austin Hospital in Melbourne during her last year of subspecialty training. She's passionate about improving neurological care through education and evidence-based medicine. And I would like to invite Dr. Shirley Lee to enlighten us on a very interesting topic. Is it seizure or not? Shirley, over to you.
Thank you, Dr. Koo, for the kind introduction. And first and foremost, I think I would like to thank CoPM for inviting me to speak today. Allow me, if I can, I will just turn off my video because I'll be sharing lots of videos just to prevent all the lags. I will share my slide now. Sorry. Can you all see my screen?
Yes.
Okay. So I've titled my talk today as Seizure or Not. And rather than the traditional approach of lecture styles, I decided to take a different approach, where today my presentation will be entirely case-based with videos highlighting seizures and also their mimics. And there'll be lots of questions and polls, hence I encourage whoever that's logged on virtually, please respond so that we can have much more engaging interactions. So with each case, I will share some clinical pearls and I'll end with a very brief take-home message. So let's kickstart with our very first case. So I have a young lady in her 30s. She was pregnant at the time, being referred from the ONG department to our neurology fraternity for multiple recurrent episodes of abnormal movements. So because the video is rather short and it was actually being captured by the healthcare staff in the ONG ward, I'll play it twice, and this will be followed by a question.
Ikut.
Okay, I'll play it. Hold on, I try to minimize this. Okay. Okay, I'll play it again.
Ikut.
Okay, now that you have seen the video, so what do you think the event that was captured in the video? Could it be an epileptic seizure, a movement disorder, or a psychogenic non-epileptic seizure attack? So maybe I can get Afik to help me pop up the question. So I'll give you about 30 seconds for you all to make a choice before I close the poll. Okay, so it's interesting that actually a majority of you think this is psychogenic non-epileptic attack, and some of you think this movement, and a minority thinks that this is an epileptic seizure. So let's move on. Okay. So wait, there's actually more to this. The family actually provided us videos at home as well. That's been taken at home. So let me play the video for you. Okay, maybe I just play another time. Okay, so now looking at these two videos, one is taken in the hospital, one is taken at home. What do you think these events were? Were they epileptic seizures, movement disorder, or do you think it's PNES? Okay, I can still see that a majority of you chose PNES, and 27% of you chose movement, and the minority of you chose that these are epileptic seizures. So let me review the answer to you. So in actual fact, these events were truly epileptic seizures. So given that now I tell you that these are epileptic seizures, how would you classify the seizure type based on 2017 ILE classification? Would it be generalized tonic-clonic? Would it be focal to bilateral tonic-clonic seizure? Would it be focal hyperkinetic seizure or focal automatism seizure? So I give it about 30 seconds for you to respond. So interesting to know that most of you chose focal hyperkinetic seizure, and some chose focal to bilateral tonic-clonic and focal automatism, and just a minority chose generalized tonic-clonic seizure. Let's move on. I would like to take this opportunity to just flash out to you the ILA 2017 classification of seizure types. This is the expanded version. There is a simpler version. As you can see that it's been almost 8 to 9 years since the classification has been out, but I understand that a lot of us still very inclined with using the old classification, which seemingly seems a bit more straightforward. But maybe after today, I hope that I can walk you through how you can easily utilize this classification to classify seizure type. And hopefully you'll be able to use this more frequent down the future. So whenever we look at seizure types, we usually look at their onset, whether could it be focal at onset or generalized or unknown onset. What do you mean by unknown onset? Let's say from the first encounter with the patient, from the history and description, and we still didn't have any EEG or MRI to guide us. At times, it is difficult to tell the onset, so we can classify as unknown onset. So under heading of focal onset, let's say from the EEG or MRI, even from the seizure simulology, it looks like focal at onset. You classify the seizure type as focal onset. And the first thing that you can classify further will be the awareness. So what does that mean? Awareness means that if a patient is aware during the seizure, which means they know what's going on throughout. However, if the patient have impaired awareness, meaning to say if someone is interacting with a patient where during the seizure, they stop responding, or patient feel that there's clouding on consciousness when you ask them to relate the seizure, so that will be impaired awareness. So at times, sometimes patient can start with focal aware and then progress to impaired awareness towards the latter part of the seizure. You will still classify under impaired awareness seizure. So just to let you know, the answer for the previous question was actually a focal hyperkinetic seizure. So under the heading of focal seizure, we can further so-called subdivide them into motor onset or non-motor onset. So what essentially that means is, you just imagine yourself as an outsider watching the patient having a seizure in front of you. Does the patient at the onset of the seizure, do they exhibit any motor phenomenon? Meaning to say, if the patients, let's say for temporal epilepsy, they typically have fiddling movement of the hands, and that will be under focal automatism. In this case, like you can see the patient was throwing herself back and forth with very large amplitude kicking movement and pedaling movement. So the best way to classify her seizure type would be focal hyperkinetic seizure. So I just elaborate a bit about what do you mean by non-motor onset seizure. So non-motor onset seizure essentially means that as an outsider, you may not see any manifestation. There's no obvious motor activity that you observe in a patient who's having seizure in front of you. So the patient can subjectively report things like palpitations. They feel like they have difficulty in breathing. These are autonomic symptoms. Or for example, a patient just say that I have one-sided paresthesia that lasts for a minute. So this will be focal aware sensory seizure. So at times, if the focal started with focal, they progress to become bilateral tonic-clonic. That's how we classify as focal to bilateral tonic-clonic seizure. I just want to highlight that a lot of times when emergency department, we always refer as generalized tonic-clonic seizure, but in actual fact, these are not always true, because the family tends to witness usually the later part of seizures when patient falls down, and when they hear the loud thud, and when the family attended, usually the patient would have generalized to bilateral tonic-clonic. So in that case, usually best is to classify them as unknown onset with tonic-clonic. So this is actually the EEG of this patient. You can see that's very angry looking. Not sure whether you can see it. Okay. There is very angry looking discharges that's arising from the left frontal temporal region. How do I stop this? Okay. So how do I erase this? Okay, so I would like to just play again the video, and this time I will do a running commentary to how I would describe this seizure. So you can see that the patient was sitting up, throwing herself up, forward and backwards. And she had quite a lot of repetitive movements, sweeping her hands, and you can see very violent, large kicking movements. And at the background, you can hear that she was making some noise even during the seizure. So this leads me to a next question. So can hyperkinetic seizure have retained awareness? So please respond. So it's either yes or no. Okay, so the majority of you got it correct. And in fact, hyperkinetic seizures can have retained awareness. So what can we learn from this case? So I just want to highlight that some seizures at times can look very bizarre, with complex motor movements that can be easily mistaken as PNES. And in actual fact, this case, the patient was actually referred from the ONG for a PNES attack. Just that when we saw the video that's being shared with us and how stereotyped it is, and we were quite certain that this could be a frontal lobe epilepsy actually. So how do we define hyperkinetic seizures? Typically, they are characterized by complex motor behavior involving proximal segment of the limb or trunks, producing pedaling, kicking, pelvic thrusting, or rocking movements. So hyperkinetic seizures can originate from frontal lobe. Much more less frequently, they can also originate from temporal lobes. So the key to it is, when would you suspect this is an epileptic seizure? When it's fairly stereotyped. If you can see the video that's taken at hospital and also at home, the features are fairly stereotyped. And especially when a seizure that occurs in during nocturnal, these are much more likely to suggest that the attack is truly epileptic in nature. So frontal lobe hyperkinetic seizures tend to be very sudden and brief, like what you see in the video. Typically, they are less than 30 seconds, with very minimal or even at times absent post-ictal confusion. So the awareness can either be impaired or retained. In this case, when we asked back the patient actually said that she had no recollection of the event, but there was a quick return of conscious level when the hyperkinetic seizure stopped. But what I want to say is the awareness can be either impaired or retained. At times, they can fully aware, just that they have no control over the entire event. So I just want to stress the importance of taking collateral history. And if you're not sure, in this day and age, we can always take our video with our phone. So let's move on to our second case. So I have a 12-year-old girl here with no prior medical illnesses, and she was admitted for twitching over the face. She also reported a 3-day history of unwell, fever, and cough. So let's look at the video. So I'll play it again since the video is pretty brief. So what do you think was the right facial twitching? Do you think it's a focal seizure? Was it a right hemifacial spasm, or was it a motor tics? Okay, so most of you chose that it's focal seizure, and you all got it correct. I just want to highlight hemifacial spasm usually typically are a bit more irregular. They are not so rhythmic as you saw in the video. So this is another video that was captured in hospital. Okay, now my next question for you is, how would you classify the seizure type based on the ILA 2017 classification that I showed you just now? Do you think it's a focal myoclonic seizure, or do you think it's a focal clonic seizure, or is it a focal tonic seizure? Okay, I can see the majority of you chose it's a focal myoclonic seizure. But in actual fact that the answer to this question is focal clonic seizure. So how do you differentiate between these two? Myoclonic typically is described as irregular jerks. And as you can see in the video, the jerks were actually fairly rhythmic and probably occurring about around 2 Hertz per second. And what is focal tonic seizure? Focal tonic seizure means increase in tone. So usually they will just have a pulling of the face without the rhythmic jerking. So I just flash out the classification for you again. The answer to this question is focal tonic seizure. So move on with this case. Patient continues to have multiple focal seizures in ward. So what do you think is the most likely etiology? Could it be infectious, autoimmune, structural, or metabolic or toxic? So most of you chose as infectious and some autoimmune, some structural, some metabolic. So I'll not review the answer, but I'll just walk you through the case first. So what we did for her, we loaded her with anti-seizure medications because she was implicated with lots of recurrent seizures. As you can see just now, it was initially from the right and became the left. And we covered her with IV antibiotics with acyclovir as well. We proceeded with neuroimaging, where the plain CT brain did not show anything, but the contrasted CT brain showed some meningeal enhancement. And we proceeded with lumbar puncture. We did not show any cell counts, the protein were normal, and the glucose ratio was normal as well. The CSF cultures were unrevealing, and AFP and also TBPS PCR were negative. So when we did EEG on her, we could see there were bilateral lateralized periodic epileptiform discharges that are arising from both temporal lobes. We also sent the CSF NMDR to the IMR, and it came back as negative. And the HSP1 came back later as positive. So hence, we completed her with 3 weeks of acyclovir, and over time, her seizures improved and she improved clinically. And we performed the MRI subsequently down the road, and it showed left temporal and encephalomalacic changes. So I just want to highlight to you that what seemingly seems like acute symptomatic seizures that initially caused by a HSV encephalitis, now she has evolved to become a chronic epileptic patient due to the scarring at the left temporal region. So what can we learn from this case? I just want to highlight to you that a few possible etiologies of acute onset refractory seizures in a patient without prior epilepsy diagnosis. Always rule out infectious because these are potentially treatable. One of the common causes or viral causes will be HSV or varicella zoster. We can have bacterial causes such as TB or even other bacterial abscesses. We can have parasites or fungal such as neurocysticercosis or cryptococcal infection. Not forgetting autoimmune and paraneoplastic encephalitis as well, even though they tend to probably present much more subacutely, but at times they also can present with acute refractory seizures. So things that are some examples by anti-NMDR, LGI1, Caspar, but usually these are in the older population, or even your GABA, anti-GABA A and B. Structural causes at times can cause. So imaging is important in this case, especially we need to find out whether a patient had history of TBI or even brain tumor. Other things like focal cortical dysplasia or even acute cortical stroke rarely at times also can present with acute onset refractory seizures. Not forgetting metabolic and toxic causes because these are again potentially reversible. So make sure you do your blood test to rule out uremic or hepatic encephalopathy. Look through the drugs that can cause seizures. Some of the drugs like antibiotics in a patient with renal failure can cause seizures as well. And electrolyte imbalances like hypo or hyperglycemia, hypocalcemia or hyponatremia can cause the patients to present as seizures, even though these tends to be more generalized. So in short, always try to rule out infection and consider autoimmune and neuroimaging, and it's crucial in this scenario. So I'll move on to the third case. I have a young lady in her early 20s from district, and she was diagnosed with epilepsy for several years. And the seizure type documented as having generalized tonic-clonic seizures. And she was always on anti-seizure medication until when during the COVID lockdown, she had a difficulty accessing healthcare, and hence she stopped her medication. So in early January 2023, she presented to district hospitals with multiple breakthrough seizures. As a result, she was intubated for poor GCS recovery, and she was treated as status epilepticus and was transferred to a tertiary center for further ICU care. Thankfully, she was extubated well and she was discharged with oral levetiracetam. The EEG we performed after she was out from the ICU was normal, and our impression at that time was status epilepticus due to missed medication. So several weeks after that, from the first incident, around late February 2023, patient again was re-intubated in a district hospital for status epilepticus, but this time she vouched that she was compliant to medication. She was loaded with phenytoin, and now she ended up with 2 anti-seizure medications. Again, she was able to extubate early and was transferred to a general medical ward. However, in the general medical ward, after extubation, she had a fitting episode. Again, it was documented as generalized tonic-clonic seizure, and this occurred during on call. So the houseman has attended promptly and gave her diazepam and was aborted. And she informed the MO on call and took a video. So I'd like to show you the video of the managed capture by the houseman. So we can see the staff was injecting diazepam, and they were calling out to her to ask her to open her eyes. And in fact, she was able to open her eyes and instructed. I think this episode went on for another 5 minutes. So I just played again. So the staff injected diazepam and asked her to open her eyes, and she was able to do so. So looking at the video shown, now what do you think this event was? Do you think it's generalized tonic-clonic? Was it a focal seizure? Was it a psychogenic non-epileptic seizure attack? So majority of you chose it's a PNES attack, and quite a large proportion of you also chose generalized tonic-clonic seizure, and the remaining were focal seizure. So in actual fact, we already had our suspicion. We went on to do further testing to confirm our suspicion. We did what we call a saline induction test. So what this test is actually is an EEG recording with a video. And at the same time, we explain to the patient that we'll be giving medication that may induce her seizures. And because it's very important for us to capture the seizure to help to manage her better. And if that occurs, we will be able to give another medication to abort the seizure. So these are so usually when we offer this test, typically is we have a PNES attack at the back of our mind. So I'll show you the video. So you can see, as you can see, my staff was giving the injection of saline. And she went to expose the legs to make sure we have a good view of the event. So about a minute later after the saline injection, you can see that there are some shaking movement on the right hand, which I feel much more tremor-like. At the same time, she was turning her head side to side. The teeth was clenched. In this case, her eyes were open. And you can see shaking now involving both the upper limbs, and the lower limbs were curled up. But what I want to highlight is you can see the shaking was rather asynchronous, especially at the beginning of the video. So in fact, this went on for a good 10 minutes. So I just want to highlight to you what we see in the video. So we see some oscillatory movement of the hand that is will fit much more a tremor than a typical tonic-clonic. And the movements of the shakings were rather asynchronous. She was moving her head side to side, and the teeth were clenching, and the eyes were open in this case. She was able to respond to the staff during this event, and you can see that she was tensing up her whole body and flexing her toes. The episode was very prolonged, even though I cropped the video. And she demonstrated this start and stop phenomenon where she will start shaking and stop again, and this went on and on. So when we realized that all these PNES attack, we went on to dig deeper and did reveal that she's undergoing some psychosocial stressor in her life. In fact, we also showed the mother the video, and mom said that indeed this was her usual habitual seizure. So we explained our revised diagnosis to the family, including the patient and mother, that these are actually PNES attack, and they're both receptive, and we have referred her to psychiatry team, and we managed to taper off her anti-seizure medication. So briefly about what is psychogenic non-epileptic seizure. They may look very like epileptic seizures, but in fact they are not epileptic in nature. The estimated prevalence is about 2 to 33 in 100,000 patients. I believe that a lot of times this is being underdiagnosed. And this could be a manifestation of psychological distress, where some would have report of previous trauma, such as physical or sexual abuse, or even past history of witnessing a violence. And these are frequently mistaken as generalized tonic-clonic seizures. And it's best diagnosed when you have a video EEG monitoring capturing the event with a normal EEG background. So I want to share with you some characteristics of PNES. Typically, they will demonstrate out-of-phase shaking movements, and they have this crescendo and decrescendo, which means building up and tailing off, and this waxing and waning consciousness. With pelvic thrusting and back arching, you can have this side-to-side head shaking. The eyes are typically closed during the event, even though in our case, the eyes were open. And they typically demonstrate this start and stop phenomenon. And the shakings involving the all four limbs, but usually they are still responsive. And there is absence of post-ictal phase, where usually in the post-ictal phase, we experience deep, noisy breathing, patient will be typically drowsy or confusion. And PNES attack, this phase will typically be absent. So I inserted a slide here trying to describe what is generalized tonic-clonic seizures, because I find that many times, many different doctors will always label as generalized tonic-clonic seizures. But it is important to know what generalized tonic-clonic seizures so that we can better diagnose our patients. So generalized but very self-explanatory, that means that bilateral synchronous discharges involving both the hemisphere. And a tonic means stiffening, and clonic means rhythmic jerking. So the tonic phase will precede the clonic phase, and during the tonic phase, all the muscles stiffened, the air being forced past the vocal cords and cause a cry or groan. And at this point, they would have lost consciousness and patient will fall. Subsequently, the clonic phase is where the arms and legs will begin to jerk rapidly and rhythmically, bending and relaxing at the elbows, hips, and knees. And usually they will last about a few minutes. And towards the end of the seizure, the jerking will typically slows and gradually stops, rather than stopping abruptly, which you usually see in PNES attack. They will just abruptly stop and it will start again. So the person's face may look sinus, especially if the seizure attack occurred for a prolonged period, and he or she may or may not have bladder or bowel incontinence as the body relaxes. They typically will undergo a post-ictal phase with confusion or drowsiness, and gradually the conscious level will gradually return. So I would like to flesh out this, encourage all of you to log on to epilepsydiagnosis.org, where you can actually sign up for free and log on to videos, access the videos, different kind of seizures that's being uploaded in this website. It's very informative, so hence I encourage all of you to visit this website. So what are the clinical polls that we can learn through this case? That GTC is not always generalized tonic-clonic seizures. Layman and healthcare worker inclusive. Response to diazepam does not equal to seizure, such as in this case, when the houseman gave diazepam, the seizure seemingly stopped. Whether it's a movement disorder, a PNES attack, or true seizure attack, all of these episodes can be aborted by diazepam, but they do not mean that the event was a seizure, true seizure attack. So at times we can afford to observe a bit longer before rushing for the needle. And if one patient presents with frequent status epilepticus requiring frequent intubation, especially without neurological sequelae, these are usually a red flag that perhaps this patient could have PNES attack. At any times you're not sure, always take videos. So moving on to the fourth case. I have a young lady admitted to video telemetry recording to characterize some peculiar events that occurred since childhood. So I'll play the video. Okay, maybe I do a bit of running commentary. Patient was sleeping at the time, and then she suddenly aroused. She started moving her lower legs. The carer came to attend to her. Started having quite violent pelvic thrusting. And at the background, actually, you could hear her laughing. So, in fact, this went on and on multiple times for the next 10 minutes. And she actually had a smirk on her face, which I couldn't show you because I blurred out her face. So now looking at this video, what do you think the event was? Was it a psychogenic non-epileptic seizure? Was it an epileptic seizure, or perhaps this could be a parasomnia? So, majority chose that this is a PNES attack followed by parasomnia, and only 14% of you chose these are epileptic seizure. I would like to show you her MRI. She actually have a hypothalamic hamartoma, as highlighted in the circle. And what she had was actually gelastic seizures. So what is gelastic seizure? It's actually focal seizure with bouts of uncontrolled laughing or giggling, with smiling and smirking at times. And these emotions are often forced and can't stop from happening. And typically during this episode, they have retained awareness, and it can happen multiple times in a day. At times, some people reported up to 100 a day. And they are typically associated with hypothalamic hamartoma. So other seizure types I can see with patient with hypothalamic hamartoma include absence seizure, it's atonic, tonic, and tonic-clonic seizure. So thankfully, this patient actually underwent a radio ablation therapy, and so far she is seizure-free at this point. So moving on to the next case, I have a young man under neurology follow-up for epilepsy secondary to hypothalamic hamartoma, similar to the case before that. As you can see, I highlighted in the MRI. His seizure frequency is a lot better than the previous patient. It was occurring once a year or less, and this described as generalized tonic-clonic seizure. He was maintained on 2 different anti-seizure medications. However, one day I received a call from district for multiple breakthrough seizures requiring multiple repeated doses of diazepam. So I have requested them to send me the video of the event, the episode. So this is the video. So the patient's eyes were shut. And again, the staff was administering the diazepam. Okay, I'll play the video again. So what do you think the event that captured in the video was? Was it PNES? Was it focal motor seizure? Was it generalized tonic-clonic seizure? So most of you chose that this is focal motor seizure, but in actual fact, this is a PNES attack. So what I want to stress here is PNES and epilepsy can coexist about 10 to 20% of incidents. Even though undoubtedly we think that the patient with hypothalamic hamartoma, he should have true seizures, but the one that's shown in the video, because you can see that it was more of a shaking involving the like a tremor over the right hand, but sparing the left hand, and the legs were also shaking. So it's rather asynchronous, and in actual fact, when I spoke to the patient could recall the event. So always take note if there's a change in usual semiology. If not sure, always take a video. And response to diazepam, I just want to stress again, does not always equate to seizure. So coming to our last case, I have a 67-year-old lady, complained of frequent jerking of legs while sleeping. She was referred to neuromedical team to route nocturnal seizures. So this is the video, because it's quite long, so I will just play it once.
Ambil 2 minit lah.
Okay. In fact, I cropped the video. The video was shared with us was 5 minutes long, and there were at least five similar stereotype leg movements. So now looking at this video, what do you think the event was? Was it a generalized myoclonic seizure? Was it a generalized clonic seizure? Was it a periodic limb movement of sleep? Or was it some tics or stereotypies? So most of you got it correct. In fact, this is periodic limb movement of sleep. So what is periodic limb movement of sleep? It's actually defined as periodic episode of repetitive and highly stereotyped limb movements that occur during sleep, which may or may not lead to arousal or sleep. This is best diagnosed using polysomnography, where if you can capture repetitive movements between 0.5 to 10 seconds in durations, with interval between 5 to 90 seconds between those movements. So they are seen frequently in more than 80% with patients with restless leg syndrome, or seen with other sleep disorders such as sleep apnea or narcolepsy. They can occur simultaneously in both legs, or they can alternate between legs, or even unilaterally. So what then is periodic limb movement disorder? Periodic limb movement disorder is when PLMS leads to significant sleep disruption or excessive daytime sleepiness. So the management of periodic limb movement disorder, we extrapolate it from the treatment of restless leg syndrome. Some of the medications can be tried include dopamine agonists like pramipexole or ropinirole, can be gabapentinoid based like pregabalin or gabapentin, or can be benzodiazepines. Even though some of them believe that benzodiazepine actually just reduces the arousal rather than truly eliminating PLMS. So this is just a diagnostic criteria for PLMS. So it needs to be diagnosed best via PSG, and typically they will records for adult. You need to have 15 leg movements within an hour, and it should cause significant sleep disturbances, and it cannot be better explained by other current sleep disorder. So coming to the end of my sharing, I hope by now that you are familiar with the 2017 classification of seizure type. And I just want to highlight to you that hyperkinetic seizures may look bizarre and can be frequently mistaken as PNES, and they're typically originated from frontal lobe epilepsy. And gelastic seizures, it's a very unique seizure, can be seen especially in those with hypothalamic hamartoma. And PNES and epilepsy can very often coexist. Frequent admissions for prolonged seizures or status epilepticus or frequent intubations without any neurological sequelae will serve as a red flag for PNES attack. Response to diazepam does not equate to seizures. And if you are not sure and you can't come to a conclusion by your first encounter with a patient, always ask family to take video recordings. And not all jerks are seizures. And at times, before arriving to a diagnosis of a true seizure attack, it requires us to do some detective work. So it's okay to defer the diagnosis until you gather more evidences. So with that, I hope you enjoy the sharing and the talk, and I'm happy to take a few questions.
Thank you so much, Dr. Lee, for sharing all her very interesting cases. I suppose this is a very beneficial as well as educational. And I think it's never easy to differentiate seizures with other non-epileptic episodes or attacks. And thank you for sharing with all these very meaningful 6 cases ranging from hyperkinetic as PNES, focal clonic seizure due to HSV infection, PNES, Gelastic seizure, PNES in an epileptic individual, and last but not least, PLMS. Yeah. So I think while we are waiting for questions from the participants, I think one of the very important clinical questions would be, especially given the fact that participants might be general physicians or registrars without any EEG support, without any neurology support. How would you actually differentiate a frontal lobe seizure, between a frontal lobe seizure and PNES clinically? Either the interictal event or ictal event. Is there any telltale sign that you confidently say this is FLE and this is most likely a PNES?
Like what I mentioned in my talk just now, when the event itself is very stereotyped, and as I mentioned, FLE tends to be very short and brief. They can look very violent. When it's very stereotyped, and even happen when it's in sleep, because usually PNES attack almost virtually never happen in sleep. So that will be a clue for you. Of course, if you can capture an epileptiform discharges from frontal region, or if you have MRI like a FCD in the frontal lobe, that will be immensely helpful. But I think there are clues. Typically, PNES tends to be a bit more prolonged. So maybe that the duration of the event itself can be a very important clue.
Great. We have got some questions from the participants. So one of them was asking whether, am I doing harm for initiating anti-seizure medication for a doubtful diagnosis of a seizure while waiting to see a neurologist?
Yeah, that's a very good question. That will see whether the patient presents with a first onset of seizure or not. If the patient presents with a first onset of seizure, typically we ask them to hold on anti-epileptic seizure until if they have additional information like a CT brain that clearly there's a scar that can lead to a seizure. I suppose that in a setting that they wouldn't have any EEG, so that'll be out of question. So in those cases with first onset of seizure, I think you can afford to wait to see a neurologist. If the patients have multiple recurrent seizures that is separated by more than a day, 24 hours apart, and you are very convinced from the video and the history taking, then I think worthwhile to start first, because I understand that especially the ratio of neurologists in our population is very low. So maybe the neurologist appointment can be 4 to 6 months later. If you're very convinced from the description, or best is you have a video, and you will see that it's a clear-cut generalized tonic-clonic seizure. And that's the purpose of my talk. Hopefully, I can educate you that what are truly some features that will suggest you these are truly epileptic in nature. But suppose if you are in a place where you can afford, you can have a very quick neurologist appointment, I suppose it's okay to wait. The other thing is, if it's acute refractory multiple episode of seizures, like in the second case, when a patient, you need to, what I mean is they have a secondary cause. In that case, you have to treat in the inpatient setting. So I assume you're asking about outpatient setting with a very infrequent seizure occurrences.
Well, that's a very good answer. So I think the way I see is that the first thing is that epilepsy is still a clinical diagnosis. That's what Dr. Sherry Lee has just rightly mentioned. So if someone shows you, videos of multiple episodes, at least 2 episodes of unprovoked seizures, more than 24 hours apart, and you're very convinced that this is a true seizure, by all means, it fits the diagnosis of epilepsy. However, we do not use anti-seizure medications to test the diagnosis of epilepsy. So you can't just be saying, I'm not too certain about what's going on with this patient, and let us try sodium valproate. If it subsides, if it goes away, then this is diagnosis. So this is not the right way. Yeah. So if you can wait, we wait. Yeah. But of course, like what Dr. Lee has mentioned, if you see one unprovoked seizure and there's a reason to it, for example, a remote cause like a post-traumatic cause or a big cortical stroke in the past like MCA, and it comes in with a post-epilepsy stroke, or we call it post-infarct seizure normally. So I think by all means, yeah, you should go ahead. And you don't have to really wait for an EEG to tell you if you are convinced that this is an epilepsy. Yeah. All right, good. So we have another live question. How to differentiate an infantile spasm from an epileptic seizure? Thank you.
Infantile spasm is actually a type of seizure as well. It's just the description of the infantile spasm, description of the seizure itself. Typically, they are less than 3 seconds, and it tends to happen when they are younger at age. Typically, they present like neonatal or infants, and they will have like a what they describe as salam attack, where they have a brief tonic of the limbs. The way to differentiate from tonic seizures is they are less than 3 seconds and they tend to cluster. Once they occur a few times, and it tends to occur near awakening, if I'm not mistaken. Dr. Koo, you have anything to add?
Oh, that's right. I mean, infantile spasm, as the name implies, is a spasm, so it's about 3 seconds versus a seizure, which would be longer. And infantile spasm is usually observed in much younger population. So of course, later on, we will have cases whereby like Lennox-Gastaut syndrome, yeah, and sort of a popular syndrome whereby you can have a lot of spastic attacks, spasms, tonic spasms, or atonic. So yeah, shorter, but again, like what Dr. Lee said, is one of the seizure types. That would probably tell you that it might be useful as a syndromic, epilepsy syndrome, as a syndromic diagnosis, so that you can know, okay, what sort of medication that we should start on. Yeah. Yeah, Tucson, thank you. Can you share with us your thoughts on the first question? Tell this FLE versus PNES if you do not have EEG to differentiate. Yeah, again, I think this is a very, well, as I said, a very important clinical scenario. I think Dr. Lee has mentioned, but I think because I do not repeat what she has just advised us on, I think some of the things that we can tell is that because both conditions, medical conditions, can come in with refractory seizures. I would say the FLE typically also come in with refractory seizures. So if you think that the seizures don't really make sense, especially when there's no post-ictal phase, and it occurs not at night. It usually occurs with witnesses, yeah, meaning that at daytime, suddenly when you have your spouse around, your family members around, the more the better sometimes. Like what Prof. Raymond has always told us, if you have an MO, then registrar, specialist, consultant, the patients with PNES will be even happier to show you or to make you be convinced that this is a seizure. So they will just happen. And usually it's out of phase, different rhythmicity, different kinds of movements, so they are not stereotyped. It's always the thing is stereotyped, that we need to document. And again, like what Dr. Lee has said, conventionally, PNES wouldn't occur during deep sleep or at night. So they are very quiet versus FLE, whereby they can just wake up, and have a bizarre movement. Another thing that we can always think about is always because PNES is invariably associated with an underlying undetected psychiatric disorder. So this is another thing that we have to think about. Yeah. So it requires expertise, skills, as well as a high index of suspicion. Because, as I said, both can come in with drug-resistant conditions. And the latter one, PNES, is actually what we call, probably is not right to use the word, we call pseudo-resistant. It means actually it's not really resistant to medications. It's just because the way we diagnose it is wrong. The diagnosis is wrong. Well, interestingly, to make things complicated is that patients with epilepsy will also have underlying PNES. So they coexist, maybe up to 20 to 30%. So even you prove that that particular attack is a PNES, it does not mean that this patient does not have epilepsy. I hope I'm not confusing you all. So individuals with epilepsy, up to 20 to 30% will have coexisting PNES. So to make things complicated, this exists, and it really requires skills and expertise, as I said. But I think these are all the things. Of course, in certain cases, when this attack happens, eyes closure versus eyes opening is another thing. So usually, during this PNES, usually the patients will have their eyes closed or remain closed versus eye opening in a true epileptic seizure. So these are the things. Yeah. I hope I've answered it. Yeah.
Yep. I think that was a very good, clear explanation. I agree with Dr. Khoo that it was very interesting. Aside from a saline induction test, we actually just brought the stressor near the patient during EEG recording, and that could induce a seizure as well, a PNS attack. So sometimes we just need to help them to identify what are their psychosocial stresses.
Yeah, and it's very rewarding because patient will come in usually with 3-4 anti-seizure medications. So then we later find out that it is not, because we are barking up the wrong tree. We keep thinking that every episode is epileptic seizure until proven otherwise. Then we keep adding medications, and that's why it doesn't work at all. The so-called pseudo-resistance. Okay. Are there any other burning questions? Yeah.
I think there's no more questions.
Yep.
Yep. So thank you very much, Dr. Shirley and Prof. Khoo, for the very informative talk, and thanks for your very valuable input and time. So thank you, everyone, and we will meet again next week for a topic of Parkinsonism and Parkinson Plus syndrome. So have a good weekend, everyone. Thank you.
Thank you, everyone.
Thank you. Bye-bye.
Bye.